right, let me enable waiting room. All right.
All right. Hello, everybody. Welcome, welcome. Good afternoon to everybody. I'll give you guys a second to get connected. We have quite a nice audience. I see some familiar faces. So good to see Jane. Hey, Jane. Good to see Lenore. Hey, Bonnie. I love seeing all your familiar faces. So happy Wednesday to everybody. Welcome to our Lunch with Docs. I know for those of you on the East Coast, it is not lunch, but Pacific time, it is high noon for them. So you guys can enjoy your lunch while we enjoy our mid-afternoon snack maybe. I am excited today to welcome you to our program with Dr. Anwar Ahmed, who is a movement disorder specialist who recently joined the team at Advent Health Orlando. He recently moved there, joined from Cleveland Clinic. So he's a movement disorder specialist who just spoke to us a few minutes ago how he had also served some time at the Muhammad Ali Center. Some of you out there are patients at that center, so maybe at some point you've even interacted with Dr. Ahmed. He's going to be talking to us today about tremors, different types of tremors, and giving us a deeper insight into what is going on. So first of all, I want to welcome you, Dr. Ahmed. Thank you for joining us today.
Thank you for inviting me for this interesting discussion, and tremor is one of my favorite topics, so put it this way.
Awesome. Well, before we get real into the program, I just want to remind people that you are going to be muted for right now, but if you have questions, if you want to enable your chat, if you hover at the bottom of your screen, you'll see the little thing that says chat on there and pop it open. Becky, who is with our team, is sending you a message. You should see that. So please feel free to ask your questions throughout the conversation today, and then I'll kind of go through those and say them for you. So without further ado, I'm going to kind of hand this off to Dr. Ahmed. And I guess the first question that I have for you is if you can explain the different neurological disorders that might see tremors or might have tremors.
Sure, thank you. So before I start discussing with neurological diseases, let me just explain the definition of tremor, and it's always helpful to know that what the tremor is. You know, in layman term, you can call it a shaking, but in medical term, the tremor has specific definition. Like tremor is a kind of rhythmical, involuntary movement which has oscillations. So it's is the rhythmicity of the tremor, it separates it from the other movements and is involuntary. And what happens in the muscles are that there are muscles in different areas of the body which cause tremor. They contract more alternating pattern like flexion or extension, or they can have co-contractions of the muscles. So it's a little bit complicated there because not every tremor is very rhythmic, but we'll discuss a little bit down in different kinds of tremor and how they present. Now, there are different neurological conditions which can cause tremors. So there are many of them, and I'll start with some of the most common ones, namely like essential tremor is the most common tremor disorder, which is in general population. The second most common after that, it would be a Parkinson's disease tremor. And after that, there are a number of some other less common causes, multiple sclerosis among one, which people can have tremors, as well as the tremors after the stroke affecting certain parts of the brain. Now, there are other non-neurological causes as well, which I think the question is that if we go to that detail, there will be too many other things to talk about there. So let's focus on a little bit on the most common causes of these tremor, which I mentioned.
All right. So how about we talk a little bit about the Parkinson's tremor and the essential tremor? What's the differences between the two? Because I've heard some people say well, we initially thought it was an essential tremor. Turned out it was a Parkinson's tremor. Is that common? What are the differences between what is going on there with the tremor?
Right. So it's again, it's a very common question. This is the two different conditions as we to understand. The essential tremor is also termed as familial tremor or benign essential tremor. These terms have been used interchangeably, in medical literature or if you go online, but it's the same thing. But I use essential tremor because essential tremor can have a genetic component and sometimes non-genetic components.
Yeah, somebody's got a speakerphone going.
Hello?
Go ahead. I'm sorry. Somebody wasn't muted. I think we've taken care of it.
Yeah, so the genetic component to this tremor is 50 to 70% patients. The tremor run in the families, so either mom side or the father side of the family, which is very common phenomena we see. So usually patients who present is very important for us to get the family history. Versus Parkinson's disease, considered to be a kind of still non-genetic, but there are few percentage of patients with the young onset symptoms, they have a genetic component or more vulnerability to develop tremors. So there's a one major difference there in between these two tremors. In terms of the clinical presentation, there are two distinct conditions in which the essential tremor presents usually more symmetrically, involving, let's say, for example, both upper extremities, and tremor occurs with posture, like when the arm is put like an extension, and with activity, like eating, handwriting, or performing other motor movements. So this tremor is mainly with activity induced, whether it is in simpler words, versus the Parkinson's tremor typically is asymmetric onset versus the symmetric onset in essential tremor. So it's like a one hand, unilateral, maybe right or left, and it starts again gradually and sometimes involve the other side later in the disease process. So it may become more symmetric, but starting with asymmetric, it's very, very common presentation. And tremor happens at rest when the hand is not moving or is not motion. Interestingly, when Parkinson's tremor patient move their hands, the tremor dissipate, it decreases in amplitude. So it's very, very common clinical finding we have to look for to differentiate. The other associated signs in essential tremor could be muscle rigidity, slowness of movement, slow walking, and overall slow with daily activities. And these all clinical features are not present in Parkinson's disease. So it's not that difficult to differentiate between these two kinds of tremor. However, I have to admit, in the beginning of these two conditions, things become confusing, and we can discuss a little bit later that what are the confusing things are there. So these two tremors are not difficult to diagnose on the basis of patient's clinical history, medical examination, and then later on medication responses.
So if somebody's not sure if they have a Parkinson's tremor versus an essential tremor, what do you do in terms of diagnostics? Is that where the DAT scan comes in?
Yeah, so I think if we look at somebody as like seeing a movement disorder specialist versus the general neurologist or family physician, then the accuracy for diagnosis is different. A movement disorder expert, when they see patients in the clinic and do a good history and then a good examination of the patient, then 90% of the time, the physician can make a correct diagnosis differentiating between essential tremor and Parkinson's tremor. In those cases, the sensitivity of diagnosing is 90%. If a patient seen by a family physician and it's 70% or 60, even less than that. Or if they see general neurologist, it could be around 75 to 80%. So it changes who is seeing patient and examining. So clinical diagnosis sometimes strongly predict and indicate the diagnosis. Now, if you add a DAT scan to differentiate between Parkinson's disease and essential tremor, then the accuracy or sensitivity is 93%, and you gain 3 more percent. So in many cases, in straightforward cases, who have typical clinical features present, such as a rest tremor, slowness of movement, some walking changes, and muscle stiffness, the diagnosis is pretty clear. And the accuracy becomes close to same doing the DAT scan versus the examination. So sometimes with the very, very easy cases where we easily know, we don't recommend DAT scan, expensive technology, and it has some radiation exposure to the brain. So we recommend try medication, and we assure patient that is not, something else, is mainly looking at Parkinson's. Now, yes, there are confusing situation happens. In those cases, I order DAT scans. So that's the common diagnostic modality we use. Now, when there are red flags or abnormal signs which doesn't fit either essential tremor or Parkinson's disease, we like to add other imaging like MRI. We look for structural abnormalities like stroke or MS or multiple sclerosis. So we look for other causes, definitely. It all depends on their clinical neurological examination. So neuro exam is a key to guide us which side we should go and what we order. And there are other tests as well, which I can mention later. Those can be done to differentiate other types of tremors depending on the patient history and their presentation features.
So one of the questions in the chat was that somebody was diagnosed with both, and they wanted to know how common is it to be diagnosed with both essential tremor and Parkinson's?
Yeah, so as I mentioned, the essential tremor is one of the tremor which is the commonest movement, right? It happens in posture, it happens with action, and it rarely happens at rest. It's a very slow progressive tremor, and there are two different age of onsets which we see. The age of onset, like starting a little bit younger age, and then like between 20 to 50 year, and then after that, after 60 to 80, there's another peak where patients may be diagnosed with essential tremor. And patients go for many, many years having a postural tremor and action tremor, and they just get worse gradually. Now, when they become older, then there is a risk of Parkinson's increases. It's not due to their Parkinson's disease, it's just the age itself as a risk factor for Parkinson's disease, because brain lose dopamine cells, and Parkinson is a condition related to dopamine loss. So when this happens, they develop Parkinson's alongside with essential tremor, and we term those patients as a ET-PD combination, essential tremor / Parkinson's disease combination. So that's the one problem happens where we have to treat both to get tremor under control. There is a second possibility in some patients when they present for tremor for 2 to 3 years, but there's no other signs of Parkinson's disease, but then later they develop Parkinson's symptoms. Now, those categories, we think they may have a subtle features of Parkinson's, but they may have a tremor more predominant symptoms, but later on they develop other symptoms. So that could be another category where it can be confusing. And these tremor predominant patients, interestingly, manifest signs of like tremors in the hand, which look similar to essential tremor patient with activity, which is actually against Parkinson's diagnosis, because Parkinson's patients should have a rest tremor, not with activity. So that's get a little bit confusing there. Or in third types of tremor, patients may have a tremor due to other conditions like a stroke or dystonia. Strokes in the brainstem sometimes can mimic a tremor of Parkinson's disease. Yeah, so these are some of the differential diagnoses we have to make and keep our mind when we're examining patients.
Sounds very complicated.
Yes,
So,
it does. Yes.
if it's a complicated diagnosis, I imagine treatment might be a challenge. So how do you approach treatment? Because I'm assuming treatment for essential tremor is different than the treatment for Parkinson's.
Yeah, oh, definitely. As I mentioned before, that Parkinson's disease, the neurotransmitter we know involved is the dopamine. Brain gradually lose dopaminergic cells when we age, and by age 65, we have already lost more than 50% of dopaminergic cell in normal aging process. The diseases start after we lose close to 75% of dopaminergic cells. And that's where the disease start to manifest in the form of tremor, slow movement, muscle stiffness. So when we think about dopamine, then we think about dopaminergic medications, and there are many. The gold standard is levodopa-carbidopa, and we use very commonly, and that should help tremor in Parkinson's patients. If we have essential tremor patients, we know that they don't have a dopaminergic loss, but in those cases, we don't know what neurotransmitters we are dealing with because brain imagings are totally normal. We know that they have sometime an overactivity in different brain circuits, like cerebellum, one of the part of the brain in the back, which deals with coordination of movements. And some of the scans show that the area is hyperactive. That area is connected through the tracts, so we call them cerebellar outflow tracts, through the thalamus to the other parts of the brain. And that produces tremors or shaking. Now, the medications which calm those tracts down or those overactivity down, dampens the activity, that helps the tremor. For example, the drug pyrimidone, which is anti-seizure drug, which increases the level of certain neurotransmitters. We call them calming neurotransmitters or GABAergic neurotransmitters, supposed to help the tremor 30–40%. Now there are some, and we also know that there's an overactivity of muscle involved with the tremor. So it makes sense to suppress the overactivity of the muscles by giving a drug which can directly affect the muscle receptors, such as the beta receptors and agonists. For example, propranolol, which affects at the muscle level to suppress the tremor activity. So yeah, so we have to, first of all, make a right diagnosis and then think about what neurotransmitter we are addressing and what is our target of treatment.
Right, and there's a lot of comments in here about people who are not getting great response from their Parkinson's meds for their tremors, wondering, you know, is it something else besides Parkinson's? There's been several comments about that.
Yeah.
Anything that you want to say in regards to those issues?
Sure. Yeah, because, you know, I've been seeing Parkinson's patients for more than 20 years, seen all. I can't say see all, it should be arrogant remarks. I've seen, you know, a lot of things like you mentioning, and it would be my understanding, yes, there are different categories of patients and there are different responses to the drug, even in Parkinson's disease. And there are different mechanisms involved. Now, as I said before, the gold standard treatment is levodopa-carbidopa, and even so after the decent dose of levodopa-carbidopa, if the tremor is not well controlled or suppressed, then we have to think about, are there other mechanisms involved in the tremor production? Yes, there are other mechanisms involved beside the dopaminergic pathways. Now, those dopaminergic pathways work on dopamine receptors. There are certain dopamine receptors which are not activated by L-Dopa alone. So in those cases, we want to add dopamine agonist medications which can open up those receptors so then L-Dopa can work more efficiently. So then the combination therapy role comes into play where the tremor is not responding to one drug, then you have to try to add a second drug to make it more efficient. And in those cases, sometimes you can able to get some decent control of the tremors. There are other neurotransmitters such as acetylcholine. Excessive activity of the acetylcholine in the brain causes Parkinson's tremor also. It's been known for a long time. Before the discovery of L-Dopa, the acetylcholine, or the drug which is called anticholinergic drugs, which is blocking the acetylcholine excessive activity in the brain, supposed to help tremors. So such as drug called Artane, other name is trihexyphenidyl. Now we know it's effective for the tremor control. Now these drugs have side effects. We don't want to use those drugs as a first-line medications, but can be added to the current regimen to get better control of the tremor. Amantadine have some benefit on the cholinergic system. It blocks acetylcholine, so it can help the tremor as well. Tremors can also be helped by some anxiety medications, because we know that the anxiety is a part of tremors, which can be increasing or fueling into the tremor exacerbation. So some Parkinson's patients suffer significant anxiety, which makes their tremor significantly worse. And if you don't treat their anxiety, the tremor still persists. So alongside with typical Parkinson's dopaminergic drugs, you want to add anxiety medications on the top to get better responses. So putting, again, I say cocktail of drugs to may be helpful in some patients. Sometimes there's a mono drug or one drug would be very helpful. Sometimes we have to choose multiple drugs, but then we have to definitely think about the side effects and try to minimize side effect by using the drug which can cause least side effects. So yeah, so there are many ways to help Parkinson's tremor. And if nothing works, then we consider the surgical interventions.
All right, and I'm going to get back to that. So I guess because there's been multiple comments, what I'm hearing you say, and hopefully the message to everyone listening today is, if they're not responding to the medications and their tremors are better, or they continue to worsen, that they should continue to have these conversations with their doctor about trying different medication types.
Very
and just
true.
to continue to advocate for themselves, because I'm seeing that there's several people that are having that problem where they're not responding to carbidopa, levodopa, wondering if it's truly just a Parkinson's tremor, and maybe that they need to go back and evaluate this further with their physician.
Right, I agree. So if the tremor is very persistent and is no response to any Parkinson's medication, there are two conditions. They either may have a tremor predominant Parkinson's disease, which sometimes less likely, the medication less likely suppressed from the medication, or they have ET-PD combination, essential tremor, Parkinson, and then third thing they want to do is a DAT scan just to confirm it if it's not just a plain essential tremor. So that's very important.
Awesome. And one person's asking about CBD or medical marijuana in terms of dealing with tremor. Do you have any thoughts on that?
I've been asked this question, I don't know how many times, by my patients and in talks. CBD has, been tested for dyskinesia and tremor in small clinical trials, and people have noticed benefits in excessive movements. It can affect any excessive movements by relaxing, the central neurotransmitters and the muscle activity. However, it doesn't have a direct impact on Parkinson's disease process or pathology in the brain. It doesn't impact the dopaminergic outputs, so have nothing to do with it. So it's not addressing the root problem. It's only helping the peripheral effect of the CBD, which is short-lasted, like few hours or few days. And then the body becomes tolerant to the same dose, and dose has to be increased to get the same response. So ideally, we are not promoting the use of CBD for the treatment of Parkinson's disease. And then the CBD also has different other compounds and chemicals, which I think the THC also, which has more side effects of confusion and hallucination in older patients. So yeah, so we are feeling that we need more clinical trials to really justify the use, and also to consider about the addiction potential and tolerance level. So yeah, so it's an interesting question. We able to answer down the road. And I mentioned before, talking to Anissa about that I have attended this Movement Disorder Conference International, and I don't see any topic on this issue. So we need to raise this more with our scientific community and research it more to give you more better answers.
Absolutely. And that's why I'm so glad we're having this conversation, because I've heard many people say that they just feel like they don't know enough or don't have enough options in terms of addressing these tremors that are not responding to medications. So I want to go back to something you said a couple minutes ago, and it was regarding the surgical treatments. So can you talk a little bit about deep brain stimulation? And then also people are asking about focus ultrasound. So could you touch on both of those?
Oh, sure. So in terms of the surgery for Parkinson's disease and essential tremor, it's been started like early 90s, and it's been refined a lot. Now, the surgery, you have to understand what symptoms the surgery can address, first of all. So let's talk about the essential tremor. So the essential tremor main symptom is the tremor. And many people want to improve their tremor in their dominant hand, and then they can address, and then surgery can be offered for the other side as well. So the deep brain stimulation surgery is invasive. It requires a brain operation. It requires that a pacemaker has to be placed, or the electrode has to be placed in the brain at a certain target. For the essential tremor, the target is the thalamus, is the part of the brain which we think produce tremor, and it has tremor producing cells. And if electrically we can make the cells to stop doing those activities or make them numb, they can stop making those tremors. And it's true, it's 90% effective, and is really controlled tremor very well for a long period of time. The long-term studies have shown more than 10-year benefit of tremor control. So it's a very good and promising option for tremor control. And it can be offered for the both side. It means is that if somebody wants to start with the dominant hand, you can operate on the left thalamus for the right brain, and then for a few months later, you can address the other side and you can operate on the right brain for the left tremor. So then you can both hand. But there are some number of side effects can happen with these procedures, like speech changes or speaking difficulty, swallowing problem in rare cases, in some cases infection where lead has to be removed, 1 to 2% chance, or hemorrhagic stroke, cause some weakness on the one side of the body. So these are the side effects to keep in mind before somebody will decide to pursue. However, some patient gets so much significantly worse that they want to take a chance. Now for the essential tremor, the deep brain stimulation is effective for the hand tremors. It may not be very effective for the head tremors or the voice tremor or the leg tremor. So this is the limitation of this surgery. So the target is VIM, or ventral intermediate nucleus of the brain. Now coming to the Parkinson's disease, we have applied the similar technology, but the target is different. Now we found that in subthalamic nucleus, and this nucleus is connected to dopaminergic system. So then this nucleus provides the feedback to improve the dopaminergic output. So that system helps. So we found that if you put a pacemaker in subthalamic nucleus, it helps actually few important symptoms such as tremors, very, very important. If the tremor is refractory to medication benefit, it is still respond to DBS. Again, 80 to 90% improvement. The DBS in Parkinson's also affect and helps the dyskinesias, which is the very, very important symptom in later in the disease when levodopa start to cause peak dose dyskinesias, involuntary movement involving arm or leg. If it's mild, may not be significantly distressful to the patient, but when it becomes worse, it's really affect the patient quality of life. So that symptom goes away 90 to 100% in many patients after the surgery. The third symptom that DBS help is the on and off motor fluctuations, where the medications start to wear off every 2-3 hours after taking a dose, and patients suffer the off symptoms such as freezing of gait, falling, tremor start to occur again. So when you do the surgery, this symptoms of on response gets longer. For example, same dose of medication lasts 4, 5, 6 hours. And the fourth improvement with this surgery is to decrease the medication to 30 to 40% in Parkinson's disease. So there are a lot of benefits in the surgery. However, the surgery will not stop the progression of the disease. It's not the cure. It has side effects similar to essential tremor surgery, stroke, infections, trouble with speaking. It can also cause worsening of cognition in some cases, and sometimes the balance difficulty may not improve. Patients' gait may not change, and that's very difficult to treat symptom even with drugs. So yeah, so there are differences. So the target is subthalamic in Parkinson's. Now there's another target called globus pallidus internus, or GPI, that has been tested. It has similar effect like subthalamic nucleus, but we use sparingly for other symptoms. Like if some patients with Parkinson's show a lot of dystonia, or they have a lot of dyskinesia, they may respond to GPI stimulation. So we select patients whenever we decide somebody is a good candidate. We really discuss all these things in detail and then select the suitable cases who can do best in our knowledge.
Okay, great. So how about this focus ultrasound?
Yes, so the focus ultrasound is a newly approved treatment from the FDA. Initially, it's been approved for essential tremor and only for the one side. This treatment has been designed on the previous experience with gamma knife, or the old treatments, we call them pallidotomy, thalamotomies, like they used to make a lesion in the brain, like putting a hot electrode in the brain to just burn those cells. It used to be 1980s, 90s, and they have tried these strategies. We call them thalamotomies. So they think that this is too much, it has too much side effects. So why not be something a little bit maybe less invasive and have involved no brain cutting, no hole making, no wire putting, no batteries, just one-time deal. So it's very intelligent that they came up with this solution where they're focusing very high energy ultrasound waves on the targeted areas of the brain where they think there are the cells for tremor are located, and they just burn those cells and make a lesion there. And that should be done under the MRI guidance. So it requires that patients should lay in the MRI with a special helmet on the head. That helmet has capability to focus ultrasonic wave toward the area of the brain where they put heat, at least 60° centigrade temperatures for a few seconds, which can burn those cells. And then you can examine patient after providing that kind of treatment, and you examine their tremors, and if tremor improve, then this is a good thing. And if not improve, they will give another shot, the same place, to get the same heating protocol, and then re-examine patient again. So that's done in 2 to 3 hours time, putting patient under special MRI, and then the physician and the neurosurgeons working together to find the target through the MRI imaging in live and looking at those brain structures where they think the tremor is coming from. Now, there are some pros and cons of this surgery. One is that surgery right now only approved from the one side of the brain. Like if somebody has a right hand tremor, we can offer this to the left side of the brain. And then if you do the other side, there's a risk of developing more swallowing or speaking difficulties because the thalamus is the part controls the other functions. Another problem sometimes happens that initially there are side effects, sometimes feeling of weakness on the one side of the body because the thalamus is close to the area where the brain fibers for the muscle strength is passing by. And if you make slight damage there, you can cause stroke-like symptoms. Sometimes transient balance difficulties with these tremors, which last up to 6 months, and sometimes dizziness or some edema of the area where you are causing these lesions. However, these are all treatable causes, and many of those side effects goes away over 6 months to our knowledge. Sometimes it's rarely permanent. Now, these patients who are qualifying for these surgeries are mainly older patients. They may not be a good candidate for the surgery, and they have high risk for surgery. So somebody who's not good candidate for deep brain stimulation, they can have this surgery. Now, the surgery is not as efficacious as DBS. It gives you 60–70% improvement of tremor versus 90% of the tremor improvement. Now, after one shot of that procedure, you cannot redo it again because it's a high risk of more complication in some cases. However, we are working to make sure that in future that may change. And also, there are experiments going on for the other side of the surgery as well, and it may be offered in future for the other side. So yeah, so there are things are being researched on that area as well.
Fantastic. And someone asked if there is any kind of exercise or use of weights that can help exhaust the tremor or to reduce the tremor.
Actually, many tremors get worse with exercise, unfortunately. Anything is strenuous exercise, yes, it makes tremor worse. Resting can help. Now, sometimes putting a weight on the wrist can help. Like if somebody has the utensils, which you can buy online, and they're heavy utensils, it can decrease the amplitude. It dampens the tremor, so then they can eat better. Different companies are out there making some kind of these utensils where you can wear them as a Velcro on your wrist and then eat. And that helps some of these things. There are devices which provide some interesting vibrations to the hands, and they can dampen the tremor. I've seen that also. I have not seen any patient of mine using it, but they mentioned to me. But there are no typical exercises for the tremor. I think only thing you can do to relax, meditate, sometimes decreasing stress level, decreasing the stress hormones definitely help. Caffeine can help. Cutting down on caffeine can help the tremor. Also, too much stimulants like caffeine or nicotine makes tremor worse in some cases.
And somebody said that, or wanted to know, is it possible for a tremor to spontaneously reduce over time, that they're noticing that theirs is getting better?
Yes. So it depends on what tremor they're asking. That's very common phenomena in Parkinson's disease, that some patients start with tremors, look very prominent, but after a few years, brain develop a different other mechanisms, and they have other symptoms, such as their movement gets more slowed down. The slowness of movement itself decreases the tremor frequency and then intensity. So they may be seeing that phenomena in Parkinson's. However, in essential tremor, I don't see that pattern in many patients. They remain same or they get worse with the age.
Okay. And I have heard of people that have tried like vibration therapy and have noticed a reduction. Have you heard of this or know anything about that?
Yeah, I heard about my patients, not read about this, but there are different mechanisms involved. As you know that the brain gets different input from our limbs. So if I giving a vibration to the brain in a limb, sometimes the brain think and then it adapts against it. So brain has very unusual mechanism of plasticity. So I don't doubt that this mechanism can help some patients, where if they provide certain vibratory frequencies, it may retrain the brain, and it's possible. Now, I don't have any clinical scientific study to cite to tell you, but it's an interesting thought. It should be researched more.
And then someone said light therapy for tremors.
Never heard about that. Sorry.
All right. And acupuncture, because people are looking for anything that that can help them and manage these tremors.
Yeah. So if the muscles, like such as in our arm, they are connected. For example, the trapezius, the neck muscles, the triceps and the biceps, and they are sore in patients who are constantly tremoring. Now, massaging the muscle, relaxation, and sometimes an acupuncture therapy to help the nerve endings there to relax those muscles, I think is worth trying it.
Fantastic.
Yeah.
I'm loving some of these comments about using humor. Someone says they're actually trying to invent something that can benefit from all this constant movement, like a cradle rocker, milkshaker maker. So,
yes.
Talking about reduction of stress, laughter is definitely a positive way of doing that.
Right.
So you mentioned earlier dystonia. So can we talk about that? Does dystonia also cause tremors?
Yeah. So there are different types of dystonias. Some dystonias happens in Parkinson's patient. that's different. And there are dystonias, which happens without Parkinson's and is the diagnosis, which is like, for example, if it involves the neck, we call them spasmodic torticollis or cervical dystonia. That happens in adult life. Some patients have tremor and some don't. Their tremor is diagnosed by neck posture. Some patients, the neck goes to the one side, and then the other muscles, which are the antagonists, they pull the neck to the other side. So it becomes like very irregular patterns of tremor, and Botox is very helpful treatment in these patients. When you calm those muscles down, that can help their tremor significantly. There are certain medications in these situations may be helpful. So that's a dystonia. We call it primary adult onset dystonia. It has nothing to do with Parkinson's disease or essential tremor. Essential tremor patients also have a neck tremor or head tremor, but not dystonia. And their tremor is like without the abnormal neck posture. Its neck is pretty neutral, and they go side to side in very rhythmic fashion, versus the dystonia tremor in the cervical dystonia patients is more arrhythmic. And in them, the Botox is really great option, even with the essential tremor patients. Parkinson's disease, when it manifests, it can cause dystonia in different parts of the body. Neck is very less likely. They have dystonia of the hand, abnormal hand postures, finger curling. They have dystonia of the arm flexion. They have dystonia of the foot turning and toe curling. Now, usually their dystonia should not cause tremor. If they have a tremor, it should be primarily from Parkinson's disease. So that tremor has to be treated the same way, which we have discussed. Now, the dystonia can be treated with the help of the Botox.
Okay. And one person's saying, I have an occasional tremor in my hand, was told by the neurologist it wasn't a Parkinson's or a neurologic disease. So is there other things that they might want to look into that can cause a tremor?
Yeah, so when somebody has only one hand tremors and they have no other Parkinson's signs, definitely they need an imaging studies. They need to start brain MRI if it's normal, but if there is any indication that the tremor is present at rest, then I would still get the dopamine scan, transporter scan. If there's an indication of a nerve damage in the hand, then I would recommend getting EMG nerve conduction test. Now, if all these things not helpful, then there is another method called Tremor Analysis. Not every center has that, very few places in the country, and they put electrodes on the brain, they put the accelerometer, and they record your tremor, looking at the pattern of the tremor and muscle contractions. And there is a report comes out of it, which may indicate that where this tremor is coming from and what could be the etiology of this tremor or the cause of the tremor. So yeah, so there are different ways that we can narrow down the diagnosis. Now, put it one more point into it. If nothing comes up, then there's a red flags for the psychogenic tremors or the functional movement disorders or functional neurological disease, which can cause tremor similar to other conditions. These tremors are distractible. They are there forever. They change in frequency and they change in day-to-day basis. So these are the red flags for psychogenic tremors. But again, it needs a very thorough examination, ruling out all the possibilities, and then make a final diagnosis of psychogenic tremor, which is due to underlying psychiatric conditions, but still without psychiatric conditions such as subconscious level conflicts, stress, anxiety, and something traumatic in patient's life.
Wow. From a clinician's perspective, that's a lot to have to weed through. So can you talk about some of the atypical Parkinson's, like multisystem atrophy or like cortical basal syndrome, progressive supranuclear palsy? They often have tremors with those at times. Are those different than the Parkinson's tremors, and are they different in terms of their responsiveness to the medications?
So yeah, so let me start with Parkinson plus syndromes, what they are. Parkinson plus syndromes are, when they present, the patient have symptoms, they look similar. But there are red flags which we have to look at. Now, in general term, Parkinson's plus patients have very, very less tremor. They have not a typical resting tremor, which is the common type of Parkinson's patient manifest, and we call them a pill rolling tremor. And that's the hand motion in like supination, pronation at rest. And that's typical. If you see that, then you are pretty much sure that this is a Parkinson's disease. Now, if there is a red flag during your examination, and I give you some examples, such as in MSA patient, if you see autonomic nervous system dysfunction, like very low blood pressure upon standing, trouble controlling the urine, lot of falls, in the beginning of the disease, that means that we are not dealing with a typical common Parkinson's disease patient. Now, those patients can still also have a pill rolling tremor, but then in the further exam, it tells us that they have a bilateral symptoms and they have a distal tremor in the hand in the posture. And this tremor is very fine, and we call it polymyoclonus, which is very, very distal tremor in the fingers. Is not typical rest tremor. So those patients have MS and they have abnormal neck posture moving forward also on the exam. So we have to look for those signs and then we can differentiate on our clinical observation. The second patient you mentioned is a PSP, which is also a Parkinson plus syndrome, progressive supranuclear palsy. These patients also can present with unilateral tremor, look like pill rolling tremor, but they have additional signs. They have a fall in the beginning of the disease in backward direction. They have a poor response to the medication. They have abnormal facial expressions where the neck is more hyperextended, and they have very, very wide eye stare where it looks like different than Parkinson's patients. And their speech is changed early on. It becomes a dysarthria. We call it growling speech, like growling dysarthria, very spastic. So those are the signs we look for. And if we see those signs, even though there's a tremor classic of Parkinson's, then we still think about PSP. Then the other condition is called corticobasal degeneration. They have a dystonia of the one hand, but they have a difficulty with trouble with their movements of the hand, or called apraxia, and they have jerking tremor. Is not pill rolling. Their hand jerks. That's called myoclonus. So their tremor is different than Parkinson's disease tremor. Then there's a Lewy body disease, also similar to Parkinson's. It has different tremor, not at rest many times, but in posture and with very fine finger tremors. Did you see? Yeah. So we have to look for the tremor and then look for other additional signs, and then make us more better in terms of our diagnostic approach.
All right. And someone asked earlier, and because we're talking about other diagnoses, they asked about idiopathic chorea and if there is good treatments for that.
So so we're changing our topic to tremor from the chorea. Again, it's a very broad topic. The chorea is basically a very common disease in terms of, if you look at it, it involved mainly the Huntington's disease patients. So it's a classic presentation, which is a common neurodegenerative disease, a genetic condition. Now, term idiopathic chorea means that when we don't know the cause of chorea. If we use that term, then it means is that many times we end up, diagnosing patients with conditions such as the endocrine problems, like hormonal, like thyroid disease, electrolyte imbalance, or they may have a stroke, or they may have ischemia in certain part of the brain. And those patients can present with the choreic symptoms. If they have no family history, if there's nothing with the family history you can think of, then yes, we can call it idiopathic chorea. Then we have to really do a detail, a workup. Example, like a blood workup, looking for autoimmune antibodies, looking for doing the brain imaging, looking for strokes, checking the medication list very carefully, such as the most common drug which can cause chorea-like symptom would be the antipsychotics. neuroleptic drugs used very commonly. The term is tardive dyskinesia, but it presents as a chorea of the mouth, face, and other part of the body. Drug which blocks dopamine, like such as the nausea drugs, Reglan, metoclopramide, promethazine. So long list of drugs under the category of idiopathic chorea patients. Sometimes the chorea presents in families. As I said, the most common cause will be Huntington's, but then there are benign chorea, which may not progress to cognitive problems or other things. It just remains same all their life. Yeah, so there is a big classification, but idiopathic chorea, if you use this term, then it would implies to when there's no cause, but then you have to look for laboratory work to make your final diagnosis.
This is so complex that I think that you could just specialize only in tremors and stay busy. I'm thinking, so we have about 10 more minutes. So we've mentioned a lot of different things about tremors. One of the things that we've talked about is tremor in the hands, the pill rolling movement, but tremors can also, maybe a little less common, but they can be in other parts of the body for Parkinson's as well. Can you touch on that?
So in Parkinson's, there are, so the commonest in the hands, number one. Then the second common area would be legs. And the third common would be the chin and jaw tremors. Head tremor is very rare in Parkinson's disease. If somebody see a head tremor, then it pretty much exclude Parkinson's, but it's rare, it's very, very rare. Plain head tremor is very rare. It can happen in association with the hand tremors, like somebody the hand tremor can have a head tremor also in Parkinson's, but exclusively just the head tremor is very uncommon. So these are the common. Tongue tremor can also be seen in Parkinson's patients as well.
Okay.
Yeah.
All right. So there's been a couple of people that have asked if there is any correlation in families having PD and MS. Is there any connection with different neurological diseases?
Yeah, so it's been studied not as extensively, but looking at the patient histories and their development of Parkinson's disease. So let me explain at least my observation first. In last 20 years, I have rarely seen any patient who have MS develop Parkinson's disease or vice versa. So number one, that's the observation. Number two, there are some cases of MS patients have manifested Parkinson's symptoms, but we thought that is due to their involvement of MS lesion close to the basal ganglia structures, mimicking Parkinson's symptoms, not typical of Parkinson's, and they have responded to dopamine agonist medication and not developed full-blown PD symptoms. So it's just a very, very rare phenomena. To my knowledge, to seeing Parkinson's patients maybe in close to more than 1,000 or more than few thousand patients last several years, I have not came across a patient with MS and PD in combination. I have seen some patients with other conditions with MS in combination. I'm curious if this person asking question have seen a patient with that combination of diseases. So MS in the family would not put anybody on high risk of Parkinson's disease or vice versa.
Okay. So as we kind of wind down, here's a really good question. And I think that there may be other people that are interested in this. So this person's tremor began 6 months ago after they fell and hit their head. Is there, could that have accelerated something that was already there, or can that be the cause?
So as I say, first of all, we have to characterize a tremor, that what it is look like. Is it a resting tremor? Is it a postural or action tremor or intention tremor? Because that can give us some clues. So if somebody has hit the head, the first thing come to us is, okay, is it trauma? Is it post-traumatic? It has caused any structural damage to it. So one thing we have to very important is to look at the cerebellum, which is the part of the brain deals with the tremor all the time. So if there's any stroke, any hemorrhage because of the fall or damage, it can cause an intentional tremor in one arm. So that can give us the answer what it's caused. If the tremor is not at intention it happens at rest, for example. Yes, there are cases in which a closed head injury or concussion injury can bring Parkinson's symptoms to the surface, where somebody has a subclinical dopaminergic loss, but then an injury can trigger it. It's possible. It's been mentioned. So that's number two. Sometimes there are rare type of tremors called post-traumatic tremor, which can happen without any structural lesions. Somebody has a one injury and it can start the tremor in the hand after that injury. That's possibility. Another possibility is, again, as I mentioned before, is stress-related tremor. If some bad accident happened, anxiety, stress, conversion reaction point towards the psychogenic origin of the tremor.
All right. All right, so as we wind down, do you have like a final like synopsis or anything that you want to say to the audience in regards to tremors?
Yeah, I think the tremor is the most common movement problem. We all suffer in our life to some degree of tremor, like physiological tremor, under the situation when we get scared, fearful as a child, taking examination, tests, and when we are in a bad situation. Those tremors are very benign. We don't have to worry about those tremors as a part of normal physiological process and our internal hormones. Many tremors are fixable and related to some underlying conditions. We can change our lifestyle by cutting caffeine on it, exercising, and sleeping 8-9 hours to feel more relaxed and more happy. I think that will really impact positively in any kind of tremors. And well hydration, drinking enough liquids, and doing things for our happiness. And if something which has really become bothersome and more persistent, then you seek a medical opinion on it, and not guess yourself, and no Dr. Google, and and no self-diagnosis. So then you see the expert, and if you don't get satisfied with that, change your physician, look for the, shop around and see which you find the best, and go for the movement expert if you need to, and hopefully you will get the answer.
And I think another thing that I heard you say through this, especially for those who are really struggling to get their tremors well treated, is to keep asking and keep advocating for themselves.
Very important. Yeah.
To look at, and cover all the rocks to see what the cause might be.
And I think one thing I want to highlight, I just came to my mind, I'm sorry, I should have mentioned early on. As I say, in 20 years of my practice, so many times I can tell you this, that I have seen polypharmacy on the patient's lists, and I have found a lot of different drugs, and if we stop those drugs, it make a huge impact on patients' quality of life, improving tremors. I have, really see some of the unusual drugs causing tremors, and when we talk to the people who prescribe them, if they stop those drugs, patients got completely cured and went home and say, oh, wow, this is a great improvement. And many years they have suffered. There are many drugs. There's a long list of drugs. And when I see patients with tremor, believe me, first thing I check is the tremor list before I step into the room to get some information ahead of time. And because it's very easy fixable, and it's so easy, and it's make me so much happy that I can do small thing and make a big difference in patients' quality of life, and seen it a lot. So make sure that you look at your medication list today and see what is there, and question your physician why they have prescribed those and what they're doing to you.
That is such a great point, and I'm glad that you brought that up. It's so true.
Yeah, I missed that last one.
No, that's great. I'm glad that you brought it up. We got it in there, and it's a very important point, because I know there's a lot of people on a lot of different meds, and our bodies don't always respond well to them. So I just want to thank you, first of all, for your time. Your knowledge in this topic is amazing. I'm sure that we didn't answer every question, but I think we got to the majority of them. And it was very helpful in the way you covered all of this. So I want to thank you. I want to thank everybody that joined us today. Listen, there was a lot of really good information on here. You might want to go back and review it. It will be recorded and it will be on our website, so you can go back and listen to it again and again if you need to. I don't know that we've had a topic specific to tremors before, so I'm glad that you were able and willing to come on and give us this, and I agree, we need more research in this area. So thank you very much. We appreciate your time, Dr. Ahmed. Thank you everyone for joining us today. So before we go, something that we do, Dr. Ahmed, at the end of every one of our programs is we say goodbye to one another and do our wave. Since we can't be physically present with each other, we at least like to acknowledge one another. So great to get together with everybody today. So thank you so much for joining us. We will see you next time. Thank you so much, Dr. Ahmed. Everybody have a wonderful rest of your Wednesday. Thank you.
Nice to meet you all. Bye-bye. Have a great evening. All right. Good.
Thank you.
Thank you. Bye-bye.
Bye-bye.
All right. So I can disconnect now?
Yep, you're good. Have a great afternoon. Thank
Bye-bye.
you.
Thank you.
Bye-bye.